Good morning. I'm Guy McKee, Associate Professor of Presidential Studies here at the Miller Center. I want to welcome everyone, both here in person in the forum room and on our webinar today for our event on the topic of the fight against COVID. Has the United States entered a new normal? Our two guests today are likely familiar to many of you in the audience. First, joining us online from Washington is Stephen Morrison. Morning, Stephen. Stephen is Senior Vice President at the Center for Strategic and International Studies, CSIS, and Director of its Global Health Policy Center. He is also the James R. Schlesinger Distinguished Professor here at the Miller Center. Next to me is Mimi Riley, the Dorothy Danforth Compton Professor at the Miller Center. Mimi is also Professor of Law at the UVA Law School, Professor of Public Health Sciences at the UVA School of Medicine, and Professor of Public Policy at the Batten School of Leadership and Public Policy. You can find their full bios and their many achievements online, but I'll let you pursue that on your own so we can move on to the topic today. First, though, I do want to note that today's event is the kickoff of the Miller Center's new healthcare policy initiative, which Mimi and I will be co-directing in the coming months and years. The healthcare initiative will examine health-related challenges, both in the United States and globally, through a series of public events, scholarly workshops, and research efforts. As always at the Miller Center, our goal will be to make expert knowledge accessible to both the public and policymakers. So let's begin, and I'll direct the first question towards Steve. We are now more than 2 years into the COVID-19 pandemic. What is the current situation, and more importantly, what are the legacies of COVID-19 to this point?
Thanks so much, Gian and Mimi, for putting this all together, and a special thanks also to the Miller Center production team for this effort, and to everyone who's joining here today. Let me just run through a quick list of the difficulties, the shortcomings, the hard lessons, the tough challenges, the big unknowns, and then a list of the achievements and accomplishments, and it will be overwhelmingly skewed to the domestic. I'll say a few things, but we'll leave the global side perhaps to a later part of the conversation. We can do something similar to that, but there's just too much to cover, and I know we want to have this be an interactive conversation. So when you look at the United States, where we are now, 27, 28 months heading into this, on the negative side, the bottom line is we've landed in a pretty dangerous place. We're heading towards 1 million dead. Our fatality rate here at home is still running at about 1,000 a day. If that continues in that mode, we have the likelihood of another wave of the BA2 coming our way. That averages out at a very high number, and it's probably an underestimation. And it sets the United States apart in a very dramatic way. We have the unknown around long COVID. If you have 70 million plus infected and you have a 5% long COVID rate, that's a very large number. The 1.2 billion NIH put towards that effort's been off to a slow start. It's coming under some criticism. There's the need for much greater rigor and speed in trying to get get a handle on that. Local and state public health infrastructure have been besieged politically. They are coming under threat if their authorities have been cut back. There's mass flight of personnel. It's a crisis. There's been no effective contact tracing, isolation, quarantine capacities created across this country at the local level. Health workforce, those who are providing health care, are depleted, burned out, and demoralized, and many in flight. Many places, like if you go in the UVA Medical Center, the nursing force is half of the nursing force there are traveling nurses paid at a very, very high rate, but it's a signal of the crisis that has emerged there. Mental health disorders, pervasive, but we know too little. We don't have adequate capacity to deal with this, nor a very clear strategy. Schools, we know that we need vastly improved ventilation. We know that we need to keep schools open, but we haven't moved there yet to provide that ventilation. On the political side, we've had the hard realization that 14 to 16% of Americans are basically hardcore refusals. on the vaccine side, and we continue to have a percentage of hesitant population. Linked to that is pervasive misinformation, disinformation, conspiracy theories, and in some instances a proclivity to violence. And that is set aside against fairly outdated and ineffectual communication capacities among our public health authorities. All elements of our toolkit, vaccines, mandates, masks, and on, have been heavily politicized in this period, which has made it very, very difficult to have a civil and technical conversation around what needs to happen in the response. We've seen a precipitous decline of U.S. trust and confidence in our institutions. And just to close on the negative side, and I'll quickly hit the positives. We've always feared that the crisis of the cycle of crisis and complacency, which has marked past responses to pandemics, would settle in this case. And we're beginning to see some of that in the United States. We can talk more about that. People are claiming they're done. They're not willing to see this as an ongoing emergency. We'll talk more about funding, but the omnibus bill, big 1.5 trillion bill for funding the U.S. government, they threw out the emergency, they threw out the response numbers in that, which was a sign of a radical shift, I think, in the politics surrounding the response. On the positives, we are in a position to begin feeling, this is going to sound very contradictory, we're beginning to feel much more confident in dealing with what is thrown at us. We are beginning to acquire capacities to treat this as a more normal and predictable threat than as an emergency that requires us to really mobilize on that basis. We have our vaccination capacities, the portfolio we have, the manufacturing base. 65% of Americans vaccinated. Of those, about 45% have gotten boosters. Data system surveillance and forecasting improved. Testing at home capacity, local PCR testing availability, wastewater and genomic testing all improved dramatically. Stockpiles are up. We have made, as a government, a sustained effort at addressing inequities around racial, ethnic identities and made significant progress. I also think that it's very important to emphasize that the Biden administration has shown pretty substantial and sustained leadership through the White House COVID-19 task force and pivoted to a new strategy, which we can talk about, for this post-emergency phase, and deserves some credit for this, for continuing to work very assiduously against this. I'll stop there. Thank you.
Maybe?
So I share a lot of Steve's unhappiness, which is not my role here. My role is usually to be the optimist. But let's start with some of the unhappiness. I was talking to my students last week, and I said, I always worried that at the end of the pandemic, we would lose interest and fail to prepare for the next pandemic. I didn't fully appreciate that we were going to lose interest in the middle of the pandemic. And I'm also disturbed at a lot of really not caring about people who are immunocompromised or disabled and are therefore real risk factors for continued deaths as we look forward to the continuing surges as we're going to experience with COVID. On the other hand, I think there's room for optimism. Steve alluded to this. I think it's a quintessential American success, but not one that we should forget. We actually managed to produce vaccines, and not just produce the vaccine template, but actually produce the vaccines in a year's time. And that's an amazing accomplishment and not one we should forget. As a result of that, also, we've moved supply chain pieces closer to the United States so that those pieces are much more available to us for future emergencies. I think another piece is that this may help us with drug development in all spheres going forward. And one of the signature pieces of the Biden administration has been cancer research, and some of this vaccine work will actually play out in that sphere as well. I guess my final moment of optimism is we have come out battered, but still with our institutions intact. And that's both depressing, the battered part, but it's also comforting that we actually did it. If you look at world history, it's not something to take for granted.
That's a wonderful point, that it's easy to take for granted the things that are right in front of us that way. Yeah, but significant. Steve touched on the question of funding for pandemic preparedness. And on Monday, the Biden administration released its fiscal year 23 budget proposal, which includes, if I have the number correct, $88.2 billion for pandemic preparedness across a range of activities. Mimi, what can we learn from the budget proposal about the administration's evolving priorities, both domestically and globally, moving forward?
So the first piece is, and connected to the budget, I do want to say that the $15 billion that was cut a couple of weeks ago, that I think of as essentially bridge funds, that's going to take us to this endemic, is still necessary. We actually are in a situation where I think Jeff Zients said last week that 93% of the money has either been spent or allocated, that's already been appropriated by Congress for pandemic relief. So that's a real problem going forward. Having said that, what I found looking at the budget was actually that the Biden administration had learned a lot of important lessons from the pandemic. What was interesting to me that they had managed to pivot into where I think there are areas of real concern. So if I would look at some of these, we do need to be prepared for what will likely be over the next 5-10 years, periodic surges of COVID. There is no way to get herd immunity, so we're going to have those surges with new variations. And they've responded to that with the appropriate types of vaccine research and other testing and other mitigation methods. There is money, and this is desperately needed, especially for CDC, but there is some major funding for modernizing the CDC and FDA. We cannot go forward without that happening. Some of the CDC funding we should think about is both CDC itself and public health infrastructure, which has been to some degree in some states completely destroyed. But not only completely destroyed, we still don't have a data surveillance method that really is standardized across the country. And that's going to be essential, not just for this pandemic, but this is my negative, we need to remember we may have a flu pandemic. That's what we were actually worried about at the beginning of this one. And so we need to be prepared for that as we're continuing to deal with COVID in the future. It includes money for things that the pandemic has made worse, like the opioid crisis and mental health. And those are crucial pieces to give parity to within the budget as we think about health care. I think, I'm not going to go into the details. What I would say is I think it is a realistic budget proposal. It has possibilities of being passed. I think that there's worthy criticism that it doesn't touch on everything we need. Zeke Emanuel and a group of people working in this area issued a report a couple of weeks ago that would be much more ambitious. But I think in our current political climate, that kind of ambition is not going to succeed.
Steve, anything to add on the budget proposal? Maybe particularly on the global side.
Well, we're running out of money. Our government's running out of money at home and abroad pretty rapidly, and so there's some urgency to all of this. We're in an electoral year where everything's getting put through that prism, so it's going to be tough. And we've got to lock in progress now. This budget, this 86.2 billion pandemic preparedness plan budget is it's a 5-year mandatory budget. It comes out at about 17 billion a year. That's a reasonable number. That's a very reasonable number, and I'm hoping that it will be aggressively presented in a persuasive way. I agree with what Mimi said, that It could be much higher, and you could make a case for much higher numbers. But in the current environment, this is a good place to be. It's defensible. It's balanced. A couple of additional comments to add. I mean, $40 billion of that 86.2 is going to HHS, to BARDA, and that's a big shift. That is moving the main dominant authority and funding in developing the new tools we're going to need over the next many years to an entity within HHS. There's been a debate within the administration. Where should mission control be located? Should it be at the White House, the White House Office of Science and Technology Policy? Should it be over at HHS? That fight has been resolved in the minds of the White House that it's going to be at HHS. HHS is going to be much more muscular in these years. I agree, putting $28 billion into CDC is long overdue, and it's a vote of confidence and a recognition of the need to really repair the public health infrastructure at the state and local levels. One thing that is in this that's a very welcome addition is the funding towards biosafety and biosecurity. We know all of the debates around the COVID origin bring up this question around whether there's, in the current environment in which gain of function research and the like is being done, proliferating across this country and the world, the standards and norms around biosafety and biosecurity have been too lax, and we need to make an investment. I was very pleased to see that put in there. And on the international side, there's money for state and USAID, and within that $6.8 billion, 4.5 for the Financial Intermediation Fund, which is a priority of the White House, to try and create some new capacity, probably at the World Bank, that would be able to invest in capacity building in low and middle income countries. That still needs to be defined, but I'm very happy to see that in there. Thank you.
So the politics of passing the funding proposals are obvious and central. There's another more subtle dimension to our situation I think is worth touching on, and that's the fact that we're operating still under a national emergency declaration, and that actually gives the authority for much of what the government currently is doing. Mimi, what's the status of that? Is that likely to expire? Is it going to continue? And what does it mean? What is its importance?
So actually, President Biden extended the emergency declaration in February, and he did it so quietly that I missed it at first. And there are reasons that you've alluded to already in the politics that he did it quite quietly. There is another emergency declaration that's important to keep in mind, public health emergency, which is done by the Secretary of HHS. And both of those have an incredibly broad reach. If you think of the national emergency declaration by the president, it covers things like student loans, COBRA, evictions, rent issues, and pretty much every part of our society that has allowed certain flexibilities to be put in place. Crucial for the health systems, it actually has allowed for major Medicaid flexibility. It allows for telemedicine and other pieces that I don't know that the health systems in general could survive additional surges without those flexibilities. So that will last unless it's terminated for another year. The public health emergency declaration expires in April. I think it will be extended for a couple of months at least. Now, looking forward, this is a major political area. There has already been some action in the Senate to declare the emergency over. I think if Congress did do something like that, it would face a presidential veto. Part of me thinks in the political game that they're counting on a presidential veto. But at some point, we're going to have to do this. It's unprecedented to be in an emergency context for this many years. But if we're going to do that, we're going to have to prepare to do that. There are many people who this is a new normal for. They think this is how the world works. And unless we do that preparation, it would cause major dislocation in society.
Steve, anything to add on the declaration?
Well, I agree with Mimi's analysis that, first of all, this ending it has become a bit of a rallying point on the right. It's gotten combined with the anti-mandate, pro-freedom, broad sort of campaign that you see with the trucker convoy and some of the other protests and some of the rhetoric on the far right in Congress and elsewhere. It's a rallying point, and we can expect to hear more about it. But I think a couple of things are going to enter the equation. President Biden is going to be loath to do away with that power and authority. It's fundamental to keeping the industrial base as strong as is required. Back to the current achievements, and I would include in that the antivirals that we're seeing. The power of the White House to use its authorities under this emergency and to invoke the Defense Production Act has been very fundamental in creating this base that we have and the capacities that we have to manage the new variants that are going to come at us, to continue to vaccinate those who are willing to be vaccinated, and to make our schools safer and to move forward. So I think it would be too dangerous to give it up. And I don't see the president. I think the president will stand firm and will defend it. And I also think that many Republicans will not fight this battle. I don't think. I think they will. There are many who will see the virtue of continuing to hold that authority. I don't see. There is a subcommittee. Congressman McCarthy, minority leader in the House, commissioned a number of subgroups to prepare for the possibility of the House coming under Republican control next January. And there is a health security working group that is underway and will complete its work later this year. We don't see this emerging as a big theme within their work. Now, we could, but I think they've already sketched out pretty clearly where they're going to land, and they've also made very clear the need to be constructive and to come up with solutions that will draw bipartisan support as we head into this next phase.
So, last week was announced that Ashish Jha is going to be the COVID-19 response coordinator in the White House, replacing Jeff Zients, as I mentioned a little while ago. What do you think about that decision? And will it help us as we try to build up public health communication?
I'll take the lead on this one, I guess. This was really a striking choice that the White House made to put Jha in that position. And it's a recognition of how poor public health messaging has often been throughout the pandemic, really going back to the early days with should we be wearing masks, should we not, and continuing with questions of vaccine rollouts, particularly to school-age children, and the back and forth we saw there, the shifting guidance on masks. I think more recently, the discussion over the first round of booster shots last summer and fall was really pretty disastrous in terms of creating confusion. And to me, it's an encouraging step that someone like Ashish Jha was put into the coordinator position, because he's an individual who, as dean of the public health school at Brown, has distinguished himself with clear communication and really across partisan lines. He's spent a lot of time on television, and not just MSNBC or CNN, but outlets like Fox and even Newsmax. So he has really tried to maintain communication across the political spectrum. So I think that's in itself a fascinating development. He's also very skilled, whether it's television, whether it's social media, at presenting complex public health scenarios in a way that's easy to understand, to present an assessment of relative risks. One thing I'd note is that at different times he's angered people with extreme views on one side or the other. There's a degree to which he's probably doing something right in that sense of hewing a line that's not, mass forever or, let freedom, ring kind of a thing, that he's tried to balance risks compared to the situation. So that emphasis on messaging and his skills as a communicator, I think, is important. As we push to another level, though, there are a couple of things that are really interesting institutionally here. One is that Jha is essentially an academic. He does not have really much of any governmental experience. And the nature of a White House coordinator position is that you are doing exactly that across the many different agencies, departments of the federal government, even intergovernmental coordination down to the state and local level. So it's going to be fascinating to see, first of all, whether he's able to manage just simply that kind of intergovernmental responsibility of the actual coordination of day-to-day operations. And he will probably need a lot of support from career professionals, from folks on the White House staff as he gets up to speed in that operation. He's an extraordinarily capable individual, but the learning curve is pretty steep. I also want to touch on something else that Steve pointed to, of the possible shift of authority towards HHS, Health and Human Services, and out of the White House. And I don't know. I'm actually curious about whether this is a shift of emphasis towards the White House as a locus for communication, and perhaps also representative of that kind of shift of actual responsibility into agencies like HHS. I'm curious what both of you think about the decision, but maybe that specific question itself.
Steve?
Well, I am a great admirer of Ashish Jha. One of the phenomena of this pandemic is that a number of personalities have emerged from within the public health community that were unknown as media figures and have distinguished themselves as very effective at reaching a national audience. And Ashish is one of those. You were familiar with Lena Wynn, Monica Gandhi, Mike Osterholm, and others. This is a phenomenon where people that were in a position to try and make sense of complicated, fast evolving public health science and all of the related issues and complexities to a public that was anxious and wanted to know how it thought about this. These personalities became terribly important, and what distinguishes Ashish is that he is very humane and civil. He's very plain spoken in taking these complicated matters. He is not condescending at all, and he speaks across political lines. He shows up on Newsmax. He shows up on CNN. And he has he built a very powerful communications team behind him first at Harvard, the Chan School, and then he brought that team with him to Brown, and it demonstrated the need to invest in a very strong communications team. And he's bringing that lesson with him. That lesson's been missing in many of our other institutions that have weak communications teams, including CDC. So he also is a big innovator at Brown University in that School of Public Health, which is not been a very strong public health school, but he's begun to populate it with a quite interesting array of people. He's hired some talent on the misinformation side of things. He's very sensitive to understanding those realities. So on the outside game of engaging with the public, he's good on the international and the domestic, and he's widely respected and quite effective as a communicator, and I think it's a great choice. On the inside game, absolutely, it's going to be a tough game internally, and let's hope he has very strong deputies working with him, and he will be able to turn also to a very strong team at the National Security Council, and a strong team that's emerging in these other places that are the center of the action, including at HHS and the like. I think that the interagency team has gelled out of a period of quite intense contestation. So he's entering in a period where I think it probably is a bit more favorable. But I'm hopeful. I would add one last point. There's been a sense of pessimism and resignation and fatigue within this administration, and a bit of disarray at times in this last 6 or 8 months, and some big mistakes that were made along the way. This is an effort to renew and reset the tone and optimism around this. His appointment comes with the new budget, comes with a new pandemic preparedness strategy. There's a reinvigoration going on, and it's all part of a larger effort, which I think gives us reason, as Mimi was saying, to be optimistic. Thank you.
So the only thing I'm going to add is that public health messaging involves both science, which is what's frequently alluded to, and value judgments. Reasonable people can disagree about value judgments. So if you're talking about what are essentially coercive requirements that are being messaged in public health communication, it's understandable that that messaging can be muddled or that people will react badly to it. I think Ashish Jha will be able to balance those two pieces. I think he will be able to talk about the values in a way that reaches a broader swath of our society. And for now, I'm optimistic.
I actually have a question from a member of our webinar audience that I think is an interesting follow-up because it gets to some of the media pieces of this. Before I give that question, though, I want to remind the audience that you can submit questions using the Q&A function at the bottom of the webinar screen, and for our in-house audience, we have the microphone at the back of the room. And this question notes, in his opinion, that many newspapers appear to be somewhat biased in their selection of what COVID studies they publish. And he's also noticed an increase in fringe expert visibility. Any thoughts from the panel on this? Do you see more fringe ideas? Is the media doing a good job of representing the state of what we know about COVID?
Well, the media has a built-in conflict of interest. I think this is always true, but in a situation like COVID, it really becomes it comes to the fore. And that built-in conflict of interest is that the more dramatic you can make it, the more clicks you're going to get. And so it plays to that. We've also, over the last 20 years, this is not news to anyone, have a much more polarized media where everyone thinks of their team and you are messaging to your team. I think that's caused some issues as we're thinking about this going forward. The place where I find it most troubling, I actually think that's the society we have. I think the place where I find it troubling is in expert advice, where you are seeing people trimming their sails based on whose team they view themselves as representing at that point. I hope that we can get past that. I think we have to get past that. And so that's where I would concentrate. I'm not going to think we're going to change the media, we're not going to change society, but we do have to think about how experts talk to each other.
We've had some pretty tough experiences in this last year that have revealed that folks who are truly fringe, who are spreading patently false claims, have been elevated by Rogan on his podcasts, by the freedom and the anti-mandate gathering at the Lincoln Memorial, and on Fox and other cable networks. This has become a serious problem, and it requires a strategy. It requires a counter strategy. Makes things more difficult. A lot of the misinformation efforts have gained greater momentum. They've shifted onto a freedom agenda, and they've attracted multiple other streams of mobilization behind them, and that's reality. And it just further reveals the need for a systematic rethink around how to communicate in this period where this has become such a deep problem, and it's not going away. It's becoming more it's great acquiring greater capacity, and some of these celebrity fringe characters are doing quite well.
I'm going to shift our focus a little bit. We've talked a lot about the situation here in the U.S., but Steve, let's turn to the global situation, whether it's the vaccination effort or the larger strategies. And I'm particularly interested in the situation that's going on now in China. We're going back to stringent lockdowns. There was news today that they're going to start importing mRNA vaccines from Pfizer and Moderna, which is a substantial shift in their approach to their own internal vaccination effort.
Thank you. Just to remind everyone here, I mean, the great outliers today are China and North Korea in terms of having a severe form of zero COVID in which they've resorted to truly extraordinary and draconian measures to repress the virus with the belief that they could succeed in doing that. And they have been able to keep until recently, the incidence levels very low, but they also have instituted a vaccination campaign in China with vaccines, Chinese vaccines, which have proven not to be very effective against the most recent Omicron variants, and the variants are able to outrace these controls. And so, until very recently, I think the Chinese position was, let's just keep fighting this as hard as we can, reimposing these controls, which have a heavy toll. They have a heavy toll on locking down enormous cities. I mean, we just started a 4-day lockdown in Shanghai, rotating lockdown Shanghai, that's financial center, 26 million people. But they've at any one time had 3 or 4 cities under lockdowns with over 30 million people. That's an enormous dislocation for people's lives, but also an enormous business price paid in the economy and supply chain problems. And it's further worsened or prolonged the isolation of China from the rest of the world. And we're not, it stands in the way of reopening. And the fear is that if the BA2 variant gets out of control, you could see something happen like Hong Kong, where they were very ill prepared, very low vaccination rates among the elderly, and they've had a tragic and staggeringly high death rate in Hong Kong in this period. Hong Kong is weighing very heavily on the imagination, and plus they've had these very big outbreaks in multiple places in recent days. So what's the solution? The solution is finally to relent on mass mRNA from the West. That's been a sovereign sensitivity issue. The Chinese have been developing their own mRNA, but that's been on a slow track. They don't have the production experience and the like. They've been negotiating with BioNTech for over a year on this. They've got local manufacturers, Fosun, ready to bring this forward, and now they're going to do a deal. They need to do a 3rd dose with mRNA as fast as they possibly can, and they need to put in place antivirals as well. And that's going to be on a slower track. But can they outrace this? We don't know, but it's an interesting shift. President Xi is heading towards the Party Congress this fall, which is critical to his vision, validating his vision and extending his presidency. And the expectation was that major changes in zero COVID were not going to happen until after that. But I think the urgency of what's happening is leading them to accelerate now. And that's a good thing, frankly.
One thing I want to follow up on is the question of China's ongoing isolation. And some conversations I've had with people here who follow China closely have suggested this might be a fairly long-term kind of a situation with all kinds of ramifications for global trade and global relations. What do you think about that as we look out, as Mimi said earlier, the fact that we're likely to see surges for 5 years, 10 years. Will China try to sustain this?
The expectation seems to be that we're a few years out from reopening. I mean, we hosted just recently Scott Kirby, the CEO of United Airlines. They're one of the major carriers serving China. His view was, you know, that's the great unknown, and it's a few years out. And keep in mind, President Xi has been pushing a logic internally within his own administration that isolation is a good thing, that China needs to stand on its own and to feed its own economic growth internally. And so there's conflicting views around reopening and the value of all of that. The other thing I would add is that the United States, pre the Ukraine invasion, the United States was already in a pretty toxic strategic confrontation with China, and much of the cooperation around public health had been frozen or had decayed, and there was this question of the COVID origin, which is the investigation by WHO into the COVID-19 origin, and the Wuhan Virology Institute and the U.S. relationships in that, which are under investigation up in Congress. All of those issues are somewhat frozen, and it's chilled cooperation and raised the question of what is most essential for us as a country to be cooperating with a country as large as China on some of the fundamental issues around public health security, and how are we going to make those work around the impasse over the COVID-19 origin. Now we have the Ukraine crisis with Russia and the possibility of a hardening of a geopolitical line between ourselves, the West, and Russia and China. And what will that mean looking ahead on some of these matters? I don't have answers for that, but I think that we're heading into a different world here. I'm pleased to see that China is reaching out to Pfizer and Moderna in this way. It means they're overcoming their sovereign sensitivities. They're going to have to sell this to their own people. So that determination is being made, I assume.
Thank you. Mimi, let's turn to the war in Ukraine and the tragedy ongoing there, and specifically some of the public health implications. What are the dangers there, but also are there any opportunities coming out of a crisis like this on the health side? I think about the fact that shortly after 9/11, President George W. Bush implemented the President's Emergency Plan for AIDS Relief, or PEPFAR, one of the great successes of his administration. Is there something similar, some kind of similar opportunity here? Or is this just the disease volcano, as I believe it's been referred to, an article in the Times this past weekend?
So let's start with the disease volcano first. Traditionally, in every war, more people die from disease and other pestilence than die through arms. And I see, unfortunately, no reason why this crisis should be any different. One help is that the Ukrainian population has been vaccinated. So as we start thinking about massive refugee dislocation with millions of people actually leaving Ukraine, that is likely to at least be blunted into what would have been otherwise a real public health disaster. Having said that, we'll still have a public health disaster. Even if we didn't have a pandemic, we would have public health disasters that go along with refugee situations. Now, on the other side, is this an opportunity? I think there are a lot of differences from 9/11. If you think about it, with 9/11, all of the PEPFAR efforts and Project BioShield, et cetera, came after 9/11. We hadn't spent any money yet, and so they were a reaction. We have already spent trillions of dollars. So that piece, it's going to be very hard to go back to the coffers because of Ukraine and say, oh, this should get us excited about this. We have nothing close to a bipartisan effort going on in Congress. PEPFAR was remarkably bipartisan. It's something that should be better known because it was such a success as we think about, and really did make a dramatic change for HIV worldwide. Where I do see some optimism is how Ukraine has, at least in the short term, brought the EU together, brought NATO together. There seems to be a new kind of global cooperation. If we can channel that global cooperation into not just the defense issues and thinking about this as a purely military event, but think about it as a human event that has health consequences, I think the U.S. can lead from behind, if that makes sense.
It's funny how that phrase has had a long lifespan after the initial backlash against it. There's a lot to it. Steve, your thoughts on opportunities as well as dangers?
Well, I agree that we've seen a remarkable strengthening of U.S.-EU cooperation in the midst of this Ukraine crisis. And even before that, you saw expanding cooperation on health security. The EU has just created its counterpart to our BARDA, which is called HERA, and is investing a lot in that, and the collaborations are improving. I think that Ukraine's dangerous. COVID vaccination rates are about 35% of eligible populations. We've got a very high MDR, multi-drug resistant TB population. We have a very high HIV population. Many of them are injection drug users on substitution therapy, and we're seeing massive disruption, right? We've got a quarter of the population displaced. We've got 4 million refugees, and in all likelihood, we're going to see 6 to 8 million fairly quickly, I believe, depending on what happens. And so that's one point. The second point is, out of this, you could possibly imagine that this crisis, if it leads to a hardening of the line between ourselves and Russia and ourselves and China, the quest for new alliances. The PEPFAR Global Fund was an antidote to the invasion against Iraq. It was an alliance building set of mechanisms in some respects, and you could see a similar kind of logic begin to apply. You have President Biden on the hook to do a second summit. The timing is in flux here, and I think he will probably focus on COVID. You see the G7 approaching. We see the World Health Assembly coming up in the spring. We see a G7 summit led by the Germans, who are leaning very far forward on these matters, the Japanese coming after them. You could imagine a form of multilateral diplomacy in which those that are standing in Europe and the United States, Japan, in unison with respect to this war, broaden that enlargement. This is a year also in which we have the replenishment of the Global Fund to fight HIV, TB, and malaria. In the fall, the U.S. is leading that effort. It's seeking $18 billion from the donors. The U.S. will do 1/3 share. There's an enormous lift required in getting to that point, along with many others. So I would not be surprised if we would see some increasing reference to Ukraine and what it proves to us in terms of the dangers that it poses on the health security front, but also the need for strengthening alliances with others that need some more support with respect to health security.
We have a question from the online audience that I guess returns us sort of from the high policy questions to the personal, the fact that this does affect every one of us. And the question is this: based on your reading of evidence-based research, what recommendations are you following concerning masking and the fourth booster, et cetera? Maybe we can sort of split that up into a little bit of a discussion of the decision that came down this week to offer fourth booster to certain groups. And also, I guess, that question of how do we all manage this in this new phase that we're all in?
So I can give a start on that, and I'll speak of what I do personally. I actually watch, especially our hospitalization rate. I don't actually trust the case rate that much, because with individual testing, I think we're in a situation where the testing rates are, if they come along, they're pretty far behind. But I pay close attention to hospitalization rates, death rates. I think they're very good indicators of where we are in terms of a surge, or a surge that I care about. I am very conscious of people who have either health issues or just personal issues. Guillen's going away next week. I try and wear a mask around Guillen. I don't want Guillen, except for now. I don't want Guillen's trip to be put aside because of my recklessness, if that's how I would look at it. There are situations, I've gotten used to wearing a mask. It doesn't bother me anymore, but there are plenty of people who don't like it at all. I think we've reached the stage where we are, in each of us, making personal decisions all the time, not just our own decisions, but for our families and friends as we go along. That's not a bad thing, and probably a necessary pivot as we think about going forward with the pandemic. I think in terms of the booster, this is a fantastic example of an administration that has learned some important lessons. There's good science behind the booster. It's limited science. It comes from Israel, where they had started both the third booster and the fourth booster way ahead of us. That data was based on populations above 60. Our original inclination, as I was seeing this discussed, was 65 and above. That moved down to the Israeli data at 60, then moved even further down to 50. Which is what I think is really the remarkable piece of this. By hitting 50, even if we're in a situation where, as we're seeing states eliminating mask mandates in schools, et cetera, eliminating mask mandates in all sorts of contexts, all the other mitigation pieces are disappearing, it at least protects probably from hospitalization and death the part of the population that is not identified necessarily as having risks, but is at more risk. And so I think it addresses that problem. It addresses our interest in moving forward. And I thought it was also brilliantly messaged in the sense that they didn't go asking all sorts of questions about it. They just did it. And I think at this stage that was necessary.
Yeah, a real contrast to the way the third booster was handled.
Huge contrast.
And they did not go to the expert committees for this decision. It's fascinating.
They learned.
A management mechanism. Steve, thoughts on either the booster or kind of guidance for our choices?
I agree that this administration decided speed was really important, not 90 days of debate. And as we had last fall over the boosters, which set us back and contributed to confusion and lack of confidence in the public. So they just moved. And whether that proves to be scientifically a great decision or not, but they're moving. And it's getting ahead of the next wave, which the BA2 Omicron wave, we're not sure exactly when that hits or with what consequences, but it's at least getting the government positioned well ahead enough that people who are immunocompromised, people who are in that age category, can be encouraged, go ahead and get it, get yourself another element of protection against what's coming, because your immunity is waning. And this is a much faster creature, this BA2, and it's going to evade protections, and you don't want to wind up hospitalized or worse. And so that's a good argument. And I would remind our listeners, that our audience, that the uptake of boosters has been disappointing in the United States. It's under 50% of those who are eligible for this, and that's part of a more general kind of slackening of vaccination efforts, of testing efforts overall. So hopefully in this period, as we're looking towards another variant wave, that people will turn their attention back to this. But it's the opportunities are being provided, the incentives are being provided, but it's being done in a way a way that is not dependent on mandates. It's putting the power of choice in the hands of the individual, And I don't think we're done with mandates on masking in the future when we hit dangerous situations. I think there'll be a return to political pressure to try and protect ourselves through some seasonal or limited range masking requirements, but I think it's going to be much more localized and state-based, and we'll continue to have contestation where some governors will make this a political issue and others will not. We're not done with that debate. People are saying it, mandates are over. I think that's too premature judgment. But I'm encouraged by what they've done on the booster here.
I'll just add two observations to what Mimi and Steve have said. Mimi makes the point about paying attention to case rates, and it's really tricky. I still follow it, but I feel like it's increasingly kind of not a helpful obsession. You see fluctuations that are tough to explain. And one thing I'll point to, going back to our funding conversation. In addition to looking at hospitalization rates, one thing that's useful where we have it is wastewater surveillance. It's a tremendously informative tool. The problem is that it's only a fraction of American communities that currently do it. I mean, we've stopped outbreaks at UVA because they survey the wastewater coming out of the dorms, and they were able to contain a couple last winter. And this is something, there's funding in the budget and in the pandemic preparedness shorter-term proposal to vastly expand that, and that's one of the tools that we can use to get a handle on that. So that's a point that I would really like to see. This shouldn't be a partisan conversation. This is just technology. This is just science. Then we should have a point of agreement, because that will give us another way to monitor the situation. The second thing I will say towards the question from the audience, but towards our audience generally, if you haven't been boosted, get boosted. Yeah, the fourth booster, there's a question there of timing it, sort of like a little bit of playing the stock market. But the third booster, there's no question. You need it, go out and get it. That's something that I think we can probably all agree the science is completely clear on. With that, first of all, I'd like to offer the floor to our audience members. Are there any questions that anyone would like to ask here before we close? We've got a few minutes left, and happy to take any questions. Harry Harding. In the back of the room, yes. And please identify yourself to the group when you
Hello, my name is Harry Harding. I'll take off my mask for this purpose. There we go. I'm Harry Harding. I'm a faculty senior fellow at the Miller Center based at the Batten School of Leadership and Public Policy here at UVA. And I've been particularly interested in what you said about, I forget the exact term you used, but fringe experts or fringe scientists, as opposed to the other competing concept of trust the science. I think that a lot of people just don't understand what science is. That there is very little, especially in kind of new areas, of science that is settled science, where there's really agreement on what the drivers are, cause-effect relationships. We know what it is. For unsettled science, then you have the problem of debate and controversy. And if that is only among well-established and credentialed scientists, that's one thing. But if you have, as you call them, fringe experts, who may have political agendas, it's another. Can you help me understand more about how to deal with this problem of basically fringe experts taking advantage of unsettled science to cause confusion and even producing or carrying out disinformation?
So I'll get us started, because then I don't have to finish it.
Just real quick, I think we had a little bit of audio trouble there, but Harry's question for our web audience was essentially the nature of science and expertise, and where you're dealing with new areas of research where the science may actually not be completely settled. How do we evaluate that? How do we deal with the problem that it may be exploited by, as we put it earlier, fringe experts with a political agenda? What does it actually mean to trust the science or follow the science when the science, in fact, is actually evolving?
So I'll state for the start that even my answer is evolving because one of our audience members, a student of mine, is actually working on a paper on exactly this, and she's taking a deep dive in the context of physicians on this issue and how you would think about regulating that within the First Amendment pieces. What I would say, I think we've made a mistake, first of all, to say science says so. Even in settled science, there are times where we change our minds, right? The difficulty is we also live in a soundbite world. And the best way to think about science is to provide the evidence of the science so that you can actually show what's going on. That's difficult with a public that's not really that science literate either. So you have additional pieces of that. That's why we've come to this point of proxies, where you have different individuals whom you trust and how you're going to work with them. I think where I find the real difficulty in these fringes is they will take one tiny piece or make it up, and it gets expanded out there. I still believe, sometimes I'm depressed and don't believe, but I usually believe that the best way to fight speech is with more speech. And therefore, the best way is to overwhelm and try to reach these people in ways that, not the people spreading it, but the people they're spreading it to, through their own communities. I think you can't speech at people, you can't preach, you can't demand, but if you can reach out to their communities, you can actually, more slowly than you might like, but you can make a difference.
I think there's a long-term project here too. I speak as a spouse of a science educator, and we really do need to do a better job of teaching not just the facts of science, but the method of science and what the nature of scientific knowledge is. I think getting to Harry's question, because there really is a lack of understanding of that and of these kinds of questions. Steve, anything to add?
I agree that this is a long-term problem. Its central dimension is the absence of trust, and some of it involves focusing on how do you change political culture in this period, but also how do you create a next generation with the aptitude to, through education, to make choices and make judgments about what is false or dubious versus what is credible. And we need to do a better job at that. And maybe this is the moment where there is a greater interest in doing that. I think we're seeing the emergence of much different methodologies of research around, in a very granular way, a number of scholars across different universities and a number of outfits like Pew and Kaiser Family Foundation trying to dig in through a pretty heavy investment in survey work on a very regular basis at trying to understand how people are responding and digesting to information that they receive. And it's almost anthropological in a way. But what I've found over the last 2 years is that some of the new scholars that we're seeing who are coming at this as experts in social media, they're coming at it as anthropologists, they're coming at it as psychologists, are publishing and illuminating this, but also that the amazing contribution that's been made by some of the survey teams, survey work underway at Kaiser and Pew illuminates this. And I think we need to pay much more attention to them.
We are coming close to our time limit. Are there any other questions from our audience? Okay, well, I'll simply close then by noting that the next event, sponsored by the Healthcare Policy Initiative, will be, I believe, on April 17th, and that will focus on a new book from Miller Center faculty fellow and associate professor of media studies, Elizabeth Elsesser. Her book is on emergency technologies, crises, and inequality, and you can, just from that short description, I think you can see the implications for many of the subjects we've been discussing today, for COVID and for a whole range of emergencies beyond the narrow sphere of public health. I'll also note that for the fall, we're planning a series of larger events both on global health security and on the state of the U.S. healthcare system. So please stay tuned as those develop and as further announcements come. So thank you to Mimi and Steve for joining us. Really appreciate your insights. To our audience for joining us in person here. It's been great to actually be back up on the stage here at the Miller Center, and also to our audience on the webinar around the country and the world. So thank you very much.
Thank you.
Thank you.